Professor Jonathan Kaufman, who's a professor of palliative care and an associate director of the Walsall Palliative Care Research Centre. So without further ado, I'm going to hand over to Jonathan, who's going to talk to us about ethnic disparities in rates of opiate prescribing for cancer pain in the UK, which are exploring findings from an observational cohort study. So as before, please do put your questions in the chat. Thanks, Jonathan.
Thanks ever so much, Sophie, and thanks very much for inviting me here this afternoon to speak about a topic which I've been focusing on for the last several years, at the very least, in order to try and get money to undertake the work. So it was a long haul, but we're very delighted and perturbed by the findings from the work that we've undertaken. This work has not yet been published, so I've put some health warnings on some of the slides in relation to not tweeting or Xing some of the slides that I'm going to share with you. So I'm going to start off with quite a controversial statement from Gloria Steinem, who was the very famous American feminist, who said the truth will set you free, but first of all, it will piss you off. And the findings that I'm going to share with you this afternoon will set you free, and they might well piss you off. But the issue is, by pissing you off, we need to effect changes that really matter to the people who are living with cancer pain at a critical moment in their life. And on the slide here, I just want to share with you a couple of inconvenient truths in relation to the interface between palliative care, end-of-life care, and people who come from minority communities. There are a couple of really interesting issues from palliative medicine and BMC palliative care that have come out in the last year and a half that have had some really interesting and pointed articles that are focused on disparities or inequities in relation to people who come from minority ethnic communities. The first by Marion Gott and Kelly Sadger, and the second one that came out just a few months ago with myself and Gila Shapiro and Christian Schultz. So please go and look at those issues if you want to know more about inequity and some of the issues, at the very least, that focus on minoritized communities. I want to talk about pain, though, which is one of the inconvenient truths that are very prevalent amongst people who are living with advanced cancer. We know cancer pain is cancer. We know that it's a symptom that eclipses all other health-related concerns. And I think it's not for nothing that Albert Schweitzer said that pain was a worse enemy than death itself. We know that from quite a number of studies and systematic reviews that it can get up to as high as 94% for people in the most advanced stages of their illness. But we do know that cancer pain can be managed, at least with opioids, which have been regarded by many as being a quality indicator for high quality end-of-life care. Think about the interface between ethnicity and different cultures and pain. What I've tried to portray on this slide is all the multiple factors that need to be taken into consideration, which are patient-focused. There is a rather questionable science around biological and genetic factors that lead to high or pain thresholds. And then, very importantly, what I've shown at the bottom of the slide
It looks like Jonathan's slides have frozen, or Jonathan's...
Jonathan's frozen, yeah. I don't know whether I have his slides.
Or particularly for individuals who might come from minoritized ethnic communities.
Jonathan, you dipped out there for a second. So yeah,
do you want to turn your camera off? Because you've got a low bandwidth.
Oh. Is that better?
Yes.
Okay, fine. So this slide portrays some of the very complex factors that focus down on the experience of pain across different ethnic groups. If we were to focus specifically on ED, there are quite a number of studies that have emerged from the United States over the last several years that are focused on people attending ED with traumatic injuries or bone fractures, and the administration of opioids or other medication to manage the distress that those individuals might have experienced. Here's a really interesting study by Thompson that showed quite palpable disparities or inequities, which are time consistent between those who were white and those who were black. And within black, they have included not only African Americans, but Hispanics as well. This is another very recent study that was published by Brunson in JAMA, which again was focusing on ethnic or racial minoritized communities who were attending ED in relation to acute traumatic injury. And what they discovered, again, was some inconvenient truths in relation to the under-assessment of pain amongst those individuals, but where pain was assessed and it was considered to be associated with high pain scores, there were some very interesting disparities in relation to the administration of analgesia, for example, opioids or ketamine. Now, this mirrors some of the very interesting work by Tate and Chimble in the States in relation to ethnic pain encounters where the patient might come from a minoritized community and the healthcare professional is white, and where the individual rates their pain as being very high, there is an element of discounting by the professional in relation to how seriously they take that account, which may lead to inadequate levels of administration of analgesics to sort out the distress those individuals are experiencing. Now, what do we know about cancer and palliative and end-of-life care? Now, this is a very nice mixed methods systematic review of very high human development index English-speaking country studies that was headed up by Gemma Clark and included me and a few other people. And we discovered a number of very interesting studies, all from the United States, that demonstrated using observational data from clinical records that patients with cancer were frequently prescribed subtherapeutic doses of opioids or received fewer prescriptions for opioids to manage their cancer pain. Now, that's in the States, that's across the pond. If we look at the United Kingdom, what do we know? In fact, we knew absolutely nothing. We had a few number of studies that I was historically associated with, where we interviewed the bereaved relatives of loved ones who came from the Afro-Caribbean and white British communities living in Southeast London, where we identified some very interesting models using regression analysis, but distress associated with pain was much higher amongst the deceased Afro-Caribbean patients, according to the accounts from their bereaved relatives, after taking into account all other factors. We conducted qualitative work with people who were living and dying from cancer and asked them about what bothered or troubled them most about their illness, and that was specifically pain, amongst a number of other symptoms, where we developed a theoretical model in order to understand how some of those individuals accommodated the distress associated with their pain. But no big observational studies had yet taken place. We knew from the National Cancer Patient Experience Survey over a number of years that patients from minority ethnic communities were far less satisfied with the manner in which their pain was being managed at a very important moment in their life. And it was with this information and previous information and evidence from the United Kingdom that I'd been associated with Irene Higginson and others, that we went to NIHR. This is Sabrina, who's going to be speaking later with you, Stephen Barclay and myself, to get a grant to undertake an analysis of big linked data using the Clinical Practice Research Data Link, hospital episode statistics, and data from the Office of National Statistics.
Jonathan, you've dipped out again, so we can't hear you.
understand for the first time in this country where the...
Jonathan, sorry, you dipped
So,
out again, so we missed that. Do you want to just repeat that last slide? We missed that, you dipped out.
so we got money from the National Institute for Health Research to undertake for the first time an observational cohort study to understand whether there were any hotspots in relation to the receipt or the prescribing of opioids to manage cancer pain in the last 3 months of life. So the primary aim of the study was to examine the relationship between ethnicity and primary care prescribing patterns of opioids amongst UK cancer patients towards the end of life, and specifically in the last 3 months of life. Our objectives were to analyse and describe prescription patterns of opioids across different ethnic groups. We then wanted to evaluate the independent association between prescribing and ethnicity in primary care. And this was a rather brave third objective, which was to examine the relationship between opioid prescribing, ethnicity, and the use of health services amongst cancer patients in the last 3 months of life. We examined 3 data sets, very large data sets, going all the way back to 2011, leading up all the way up to 2021. The first was the Clinical Practice Research Data Link. This included 16 million people across 650 practices across the entire UK population. We then linked that with data from the hospital episode statistics, and then linked that again with data from the Office of National Statistics. The ability to scrutinise and interrogate data using ethnicity has only become pretty workable since 2011 onwards. And there are a number of different studies by Rohini Mehta that suggest that it's now far more workable than it historically was. So what kind of data did we include? We wanted to focus on UK cancer patients who died between these 2 time periods, 2011 to 2020. We wanted to include a number of main cancers, for example, breast and prostate and lung, as well as other cancers which are known to be associated with pain, as well as cancers which are known to be more prevalent amongst minoritized communities. Our primary outcome was to record the number of opioid prescriptions in primary care in the final 3 months of life. And we focused on what could be considered to be strong or moderate opioids, more modernly called step 2 and step 3 opioids. And then our secondary outcomes were focusing on the number of emergency department visits and what we regarded as being burdensome hospital admissions in the last 3 months of life. That was 2 or more admissions. So this is the flow diagram of the number of cases that we were able to interrogate during the course of the study. Quite a number of individuals needed to be eliminated because they were outside the study period. The ethnicity data wasn't accurately recorded and so on. But we ended up with a sample size population of just over 230,000 cases to interrogate. These are the broad characteristics of the patient cases that we examined. You can see here that the main cancer sites were breast, colorectal, lung, and prostate. Pretty similar across all of the ethnic groups. And then we wanted to describe the primary care prescriptions of opioids across the time period, across the different ethnic groups. And using these flatline graphs, you can see that there are some rather consistent time-related disparities between the green line, which represents the white British reference population, and those from minoritized communities. Now, this is purely descriptive and exploratory epidemiology. We wanted to interrogate the data further, so using Poisson regression, we incorporated a number of key variables into our regression analysis, which included the number of comorbidities that those individuals were living with, whether they lived in different geographical areas that were associated with material deprivation. So we included the IMD. We looked at settlement in terms of whether they were living in rural or urban settings. We looked at sex as well as ethnicity, the primary outcome, and age. And what we discovered were that the adjusted rate ratios for the association between ethnicity and the prescribing of opioids in primary care in the last 3 months of life demonstrated that all patients from minoritized communities were receiving fewer prescriptions than the white reference population. Now, we wanted to conduct some sensitivity analysis to understand at a more granular level what the trend was, what the signal was. So using a formula where we were able to calculate the morphine milligram equivalence, which was derived by multiplying the daily dose of equivalent analgesic ratios. And this analysis was restricted to a much smaller number of opioids because we had to rely on complete information in relation to the dose number, the frequency of the dose number, the route of administration, and the strength of the drugs that were being used. And we made use of a number of different formula to working out opioid equivalents, one of which was a very famous one developed by Curtis and colleagues, published in The Lancet a number of years ago. But what we showed here was that not only were the relative rates of prescribing less, but the amount of medication provided within the prescriptions was also less compared to the white reference population. Our sensitivity analysis also looked at breaking down the opioids into step 3 and step 2 opioids. Step 3 opioids are opioids that focus on moderate to severe pain, and step 2 opioids are the weaker opioids that focus on mild to moderate pain. Now, these bore very similar witness to the previous adjusted rate ratios that I showed before. But what we were able to see here, which was interesting, was that those individuals who were classified as being Black were more likely to receive step 2 opioids compared to other ethnic groups. What we need to do is to understand the rationale for why that might be, and we need further research to explore that. We wanted to understand the complex interplay between the primary care prescribing of opioids in the last 3 months of life, patient ethnicity, and the use of health services. And I think it's important to weigh caution against some of this analysis. We can't demonstrate causality, but there is a potential association between the possible underprescribing of opioids and the need to attend ED in the last 3 months of life. Irrespective of that, what we are able to show is, after taking all other factors into consideration, that the adjusted rate ratios for attending ED, as well as experiencing what we would refer to as burdensome hospital admissions, were higher amongst all the ethnic groups compared to the white reference population. And again, if we use the flatline graphs, we can see here that the mid counts using the person-centered months across the time period demonstrate that compared to the white reference population shown by the green line at the bottom, those from minority ethnic communities were more likely to visit ED departments in the last 3 months of life, and also more likely to be admitted for what we regarded as being burdensome hospital admissions. So there are a number of really interesting study limitations that I think we need to talk about before we make inferences from some of the findings that I presented here this afternoon. First of all, the clinical practice research data link only captures opioids prescribed by general practitioners. So we might have missed out on other avenues for prescribing from hospital, or those would be limited, and also from hospices. There are also instances in relation to the missingness of opioid data, which meant that our ability to do the sensitivity analysis in relation to calculating the morphine milligram equivalents was limited to a smaller number of opioids. What we don't have here from the CPRD data, which is what we would love to do in a prospective study, is to analyze pain intensity and prevalence amongst the individuals who were prescribed opioids. We don't have any of that data available to us in terms of matching the most appropriate drugs to those individuals who might have been experiencing different levels of intensity in relation to the pain that they were experiencing. And another key piece of information that we don't have available to us is whether any of these medications made any difference to improving the quality of life of those individuals who were experiencing pain and then were prescribed an opioid. All we have is the mere fact that they were prescribed an opioid. We don't know whether they took the medication, and we don't know to what effect. So with those questions, what we would now like to do is to go back to funding from NIHR to undertake a more exploratory and hypothesis generating piece of work to build on the reality that we have evidence for the first time in the United Kingdom, material disparities that make differences to people who are living with and dying from cancer who are experiencing pain. And we have that, which is really important, and our studies compare favourably with studies from the USA. And as I said earlier, whilst we can't demonstrate causality, what we are able to do is to show a possible association between the underprescribing of primary care prescriptions of opioids in the community with the need to attend ED and the need to experience burdensome hospital admissions. And again, those findings compare with the work by Leslie Henson in South East London and Martin Bardsley. All of this has implications for patient experience. All of this potentially has implications for patient outcomes, including quality of life, and needs to be underscored by what we refer to as clinical governance and patient safety. It can't be safe to underprescribe opioids, which lead to distress. So what we want to do from here onwards is to go back and get more funding to conduct a prospective mixed method study. We want to understand what's happening in these clinical interactions between patients from minority ethnic communities who may be experiencing pain. What does that encounter look like? Who is talking about the pain? Are patients providing accounts that what might be considered to be the wrong type of pain? So we want to explore that narrative using discourse analysis or ethnography. We need to train healthcare professionals under the umbrella of cultural safety, and we need to develop cancer pain education resources where patients can go in with greater agency and empowerment to talk about a symptom which we know on the face of it lends itself to impeccable assessment and management. And with that in mind, we need to be able to understand whether interventions like this, a complex intervention on the face of it, make a difference to the lived experiences of those individuals. I've now got an opportunity to entertain any questions that you've got. So I'm going to end the slideshow now and put my camera back on.
Christina is a consultant in palliative medicine and the academic director and research lead at Lauros Hospice. So I'm going to hand over to Christina, who's going to chair the theme, Exploring Opportunities and Learning Pathways to Reduce Inequity in Palliative Care. So over to you, Christina.
Thanks so much, Sawubona, and it's really delightful to be here. I'm looking forward to chairing this next section, which will bring together some of the initiatives that are building on what we've heard this morning about the need. So I'm sure it proves to be absolutely fascinating. And the first one is Marie Clancy, who we heard from earlier on. We know that she is a senior lecturer in the academic nursing unit in Exeter. And Marie, shall we go straight into your presentation? Thank you.
Yes, thanks ever so much, Christina. I'll just see if I can share this properly. Can you see that okay? Is it the big?
It's not come through yet.
Oh. Oh, hang on, sorry, I'll just have to stop sharing because I need to share the audio as well. I've forgotten that for a second.
That wasn't in presenter mode, I think.
No, that would look fine.
Right,
Is that okay?
Yeah.
Right.
Lovely. Well, thank you ever so much, everyone, and looking forward to speaking to you about this. So this is some work that I did as part of my PhD and have been developing further since then. And it's looking at different ways of co-producing research. And I know people mentioned earlier some interesting creative work, and I suppose this follows on from that. I am a nurse, children's nurse by background, but I'm also a secret poet on the sidelines. So I've always been interested in poetry and how that might link to understanding more about health, illness, suffering and death, I suppose, as well, particularly for my student nurses who, for some of them, they haven't got an awful lot of life experience. So it can be quite difficult for them to understand some of these complex issues. So this research is going to look at some poetic inquiry and how I use that with refugee populations. I was told that this would be very difficult and probably not possible. So obviously that was a bit of a challenge of how to actually manage that. Do just let me know if it's not moving on, Christina, or there's any problem with it.
It's come through, thank you.
Lovely. So just to say some challenges sometimes that people may share or people may be worried about, particularly when working with refugee populations, is that obviously there is a huge power imbalance. They're often, particularly for white researchers who may be in this space and may struggle to sort of find their place and actually how they can help this population without having too huge a power differential between them. I also think obviously there's a lack of insight and understanding, particularly in migration studies. It's very, very difficult to understand what somebody's been through, the amount of suffering they've encountered and the trauma of forced migration. And I think that can be very difficult to fully grasp for anybody really, particularly researchers in this field. Obviously, we've all got the potential for bias, and we all need to work harder at trying to address those personal biases and making sure they don't influence our care, but also so that they don't influence our research. And sometimes, I don't know if anybody's mentioned this already, but it can be quite difficult to access, to build, to fund or sustain advisory or patient and public involvement within research. I particularly found this so within my own PhD because I didn't have funding and I realised very much that I wanted to pay anybody who was part of my research, but I actually didn't have that money to do that. So thinking about equity and how we can do this, but also thinking that practically sometimes that can be quite difficult if you haven't got full funding or it hasn't been factored into a grant of how you might pay, such as a PPI member. There's also quite a big body of research which suggests that sometimes we mention PPI because we need to, just for ethics or perhaps for publication. They want us to have PPI or advisory groups within our research, and then it can become quite tokenistic. So I'm sure similar to a lot of you listening today, I didn't want to fall into that trap and to be part of that sort of tokenistic effort to include people in my research. So what I decided to use, and after lots of research and looking around at what might be the best option, I decided on using a reflexive cultural humility stance. And for those of you that haven't seen this too much, it's this idea of an active engagement and a lifelong process of self-reflection and critique. So you're trying to understand yourself, but also yourself in relation to others, I suppose, is the important thing here. So that you are trying to learn about another's culture, but it comes from a place of openness and curiosity. And firstly, there does need to be this examination of yourself, of your own beliefs, your biases, your assumptions, values, and your own cultural identity in order to be able to understand yourself before you even begin to try and understand anyone else. And there is this idea that if actually you can do this and you can work within this curious, open framework, which understands that we are learning all the time and we don't know everything about everyone. In fact, we know nothing about no one often. That's the way we can learn best. And what I found with my participants is that when I said to them, I've worked with some Muslim families before, but I haven't worked with you. Could you tell me what's important to you? Because that's what I'm really interested in. That worked really well. And actually families really relished the opportunity to educate me and to tell me what was important to them in that space. And as you can see here, there are some consequences if this model is used in terms of fostering more mutual respect within your relationships with people, empowering others to speak, as I mentioned there, and obviously an optimal learning environment for somebody who possibly doesn't live in this space and so does need to really understand more about what it's like to live in this space. So just to tell you a little bit more about cultural humility and research practice before I move on to the poetic side of this research, just for those of you that haven't heard very much about it, there is a really good paper by Jaeger and Bayer-Wu who talk about any clinical researchers should actually be using cultural humility in their research. Theirs does focus on nursing, but I think it has a precedence for anybody actually working clinically or with a clinical background, in order to try and be more ethical in their research and better address health inequalities. And there needs to be this sort of unpeeling. I like this idea of unpeeling layers to think about what makes up a person, what makes up the researcher, and what makes up the people that we're interested in learning more about, and thinking about personal, professional, and research values at the same time as doing that. There is this humble model which talks about how we can actually do this practically, because I don't know about you all listening, but I sometimes find with theories they don't actually apply clinically or in a practical setting, and that can be quite frustrating. So I like this humble model because it talks us through how to actually apply it. And you'll see here it's being humble about any assumptions you make and trying to avoid those, and being comfortable to say you don't know. And I think that can be quite difficult within the clinical space where we are expected to always be competent. Actually saying, I don't know, please can you teach me, or please can you tell me, can be a bit difficult at times, but it is important. We talked about self-examination already, so I won't mention that again. And being motivated to learn more about another person, I think, is very important. And I think that's something we need to inspire the next generation. Certainly it's something I try and inspire my student nurses to work towards, is that motivation and desire to learn more. And obviously we need to begin to incorporate that knowledge into our research, see the participant as an expert. I think we've all mentioned that already today, and emphasize that respect or sort of genuine interest in the other as we navigate any research interactions that we have. So just to come on to the poetry side again, some of you may not know this, forgive me if you do already. Poetic inquiry is relatively new within research, and it's described as any poetic endeavour really, whether it's before a project analysis, as part of the project analysis, or poetry that constitutes any part of a research project. So as you can see from that, it can be quite a broad use of this term, which has its pros and cons, I suppose. There are three main categories though, and for those of you that are interested, I would really recommend this textbook by Prendergast, who really explains poetic inquiry in a lot more detail. But they talk about different types of poetry used in research, and the ones that I wanted to use were participant voiced poems, because I actually wanted to learn more about my participants and their lived experience. So that's why I chose that particular area to focus upon. And you might be thinking, well, why would I use poetry in my research? What is the benefits of that? And you'll see here there's quite a lot in terms of it may increase interest in and motivation for and access to research. I found that a lot of participants were very interested. Poetry, I think, crosses a lot of cultural divides, and people are often using poetry. One of the families I spoke to had already written a poem about their son who died. So actually there can be quite a lot of benefits to using poetry, because lots of people will use it already within either their own faith or cultural practice. It can support and empower communities to add their voices to important areas of social justice. I think we've probably all seen areas of activism where poetry or literature has been used as a sort of call to action or a call to arms. So that is another element. There's also this aspect of slowing down and a reflective space and extra time to create and express. I don't know if any of you share a similar notion, but sometimes when I'm looking back at my interview transcripts, I think, oh, gosh, why didn't I ask that? And why didn't I follow that up with another question? But at the time, I'm often rushing through my questions and just trying to get them done and make sure I ask everything and cover everything. And poetry, I think, gives us this allowance of slowing down and saying, oh, you chose this word. Why did you choose that one? That's really interesting. And again, it adds value when we're asking people to explain things, that we actually really do care what they're trying to say and how they're trying to say it to us. It can also increase capacity for expression, particularly if people's first language is not English. People are surprised by that. And again, my research supervisors were saying this won't work, I don't think. But actually, again, with one family, they wrote the poem in Arabic, and then they had that translated for me. And then we had a lot of discussions about the translation. And as a fellow speaker was speaking about earlier, elements that weren't transferable and what they actually meant in their own language, and why those didn't transfer into English properly, but actually what these notions meant. So it just, again, allowed this extra dialogue, I found. I also feel it can draw listeners closer to the lived experience. Another issue we have with our students, again, is this just not really understanding someone's perspective. And I think when you hear a poem, it's a bit like hearing something musical. It can sort of touch a deeper part of people's soul, where they really get that emotive response and reaction, where they do get a deeper understanding of what someone's been through. And I also think it can help us address some of these issues within qualitative research, where the interpretations are just that of the researchers. You know, by handing over a bit more of this power to the people that we're trying to learn more about, we are actually allowing them to interpret rather than it all being our interpretation of their words. There is also something about poetry where we can include more of the actual words and terms that people use. So in one of my research interviews, a father said to me that nurses shouldn't shine a torch on the refugee. And so I asked him, you know, that's a really interesting phrase. What does shine a torch mean? And he was able to explain, and then we were able to use that within the poem to kind of explain to others that were reading it that what he was trying to say there was not to single out a refugee family as distinctly different. Actually, some of their needs are similar, and what they don't want to be is discriminated against or treated unfavourably just because of their refugee status. I also find as well that you can use words, phrases and repetitions. Sometimes I'll see a quote on a screen like this one and I'll think, well, what came before that and what came after and what was the context? And I think poetry allows you to add a lot more of that detail in as well. And you'll see there that wholeness and interconnectedness. And there is some evidence to suggest that it can improve the accuracy of interpretation as a result of some of these things. So what I did first of all, because there was a little bit of hesitancy from people around me, was I actually gained some advisory group input into whether this might be a good idea to use these things within a refugee population. The last thing I wanted to do was cause more trauma or more upset for anybody that had already suffered huge amounts, obviously. So I created these little case studies, which, forgive me, they are a little bit basic, but I used them to speak to a refugee group that was already in existence and asked them if they could help me to suggest any improvements or how these might be used with families, and whether they actually would be interested in interpreting some of these with me themselves to see if this would work. Obviously, those interpretations were quite favourable, and the feedback was quite good, and there was a lot of suggestion that people would be interested in using poetry, creating it, or reading other people's poetry and interpreting it together. And so from then, I came up with two different methods. some of my participants, as you can imagine, said, we don't want to write poetry ourselves. We don't know how to do that. We haven't got the time. Particularly some of the clinical staff that I interviewed, they were interested, but just didn't have the time to actually write something themselves and understand more about poetry creation. So what I did in that case is I used advisory groups. You'll see a couple of them on the screen there. I had a very experienced bereaved father from a local hospice, and I had some young people from the Children's Hospital who helped me. And they went through some of those transcripts with me. We had a number of meetings where we shared interpretations, and then they helped to create poems from those interpretations. There was one family who, as I mentioned previously, had written their own poems, and so we were able to use those and I gained a real depth of insight, particularly into their faith and how that affected their healthcare decision making. And this is something that I'm working on at the moment, which is about how this might be used by researchers that have never used it before, and we are trying to create a roadmap, so to speak, so that people might be able to follow some of these instructions to use them in their own research. So please do watch this space. We're currently in the process of publishing this work. And there's quite a bit about different stages and how we can prepare ourselves. A lot of people are worried about using poetry, but there's quite a lot you can do to improve your understanding and to work within that. You don't have to be a poet to use these methods. Obviously, there will be some participants that don't want to engage with poetry at all, and you do need to have alternatives. And within my research, it was certainly an additional method rather than the only method. And I think if you were going to use it as the only method, you would need to have people understanding more about the method and obviously being happy to use it before you proceeded. Generally, what we did when we created poems with people was we asked them to use words or phrases to describe their experience, and that was quite a good method within the interview to then think about how those words and phrases might be further developed into poems. And you'll see there are three main methods that we and a colleague, myself and a colleague, used within our own research to create different poems. So this first one is the independent poetry creation, where somebody creates a poem about their experiences themselves, and then they share those with the researcher in order to help the researcher understand their perspective better. And obviously, as with mine, that may include work with translators or interpreters there. Then there is a colleague of mine that I'm writing this paper with. Her research was about endometriosis, and she used focus groups to work with a support group where they wrote poems together as a group, and then they worked on individual accounts as well with her to help develop these. And then the third method, which is the one I used a lot, where we used advisory group members with different levels of expertise to help us to understand and build poetry. And certainly when discussing some of these with the bereaved father, he was really able to help me understand that experience of being bereaved and losing a child, and how that was experienced by him, but also by the participants in my study. There is then the ability to sort of check these with participants, which is why it can help your accuracy. So I sent all my poems to the participants and said, does this really reflect what you were trying to tell me in our interview, or have I misinterpreted this? And it was quite interesting, actually, that quite a few participants did come back to me and say, actually, you did miss a tiny bit here. Could you add this in? Could you change this word? So again, it's just that extra level of analysis within the research, which can help you to make sure you have really understood. And what I found is that people did really like receiving their poems, and quite one particular family emailed me back and said, I'm really glad you shared this poem because it shows me that you really kept my data confidential and you didn't reveal any revealing factors about my son's diagnosis or anything that I was worried about. So again, it can be quite a reassuring dialogue between yourself and participants as well. Obviously, there are different ways of disseminating poems as well. Some participants might like to have their name on a poem, but that sort of thing obviously really needs to be discussed really clearly, particularly within ethical applications at the beginning of research, to make sure that that's thoroughly discussed and there is informed consent there if anybody's identity is going to be revealed later.
Are you able to round it off, Marie?
Yes, sorry, there is a little poem at the end. There is just some summaries there of how important it is, but I will just share this poem, if that's all right, Christina, just to finish off. This was a poem that was recited by some siblings, and you'll see it's actually written on the left-hand side, and they're going to recite it on the other side. I've just tried to turn the volume up so you can hear it as well as possible.
Comfort maker, safety seeker,
hostile and restrictive,
pain reliever,
difficult communication,
media negativity,
need assessor,
political victim,
uncompassionate,
system juggler,
persecution fleer,
tainted by the few,
influenced by background,
family first,
entitlement focused,
time limited,
frequently misunderstood,
unseeing and unknowing,
burdened,
exhausted and unheard,
distance from reality.
Thank you so much.
Thank you, Marie. You definitely left us wanting more. My instruction is to have all the presentations and then to have questions about yours and other presentations at the end of the session. But thank you so much for that. And that poem at the end has left us all thinking, I think. So Zobia, you are next to present. I hope you've changed your hat from chair to presenter. And you've got a hard act to follow, I feel.
I certainly do.
So I don't think you need any introduction, so let's go straight into your presentation. Thank you.
So I'm going to try and share screen. If you could just let me know when you can see it, that would be great, and that you can hear me okay.
Slides have come through, they're not in presenter mode yet, Zobia. But...
Yep.
Yes.
Okay, so hello again, everybody. I'm going to now talk to you about some of the work that myself and colleagues have been undertaking over the last 5 years, which is addressing inequality and equity in palliative care for individuals from underserved, ethnically diverse communities, specifically with the aim of supporting healthcare professionals to make end-of-life care accessible for all. And I'm going to use the term ethnically diverse within this presentation to refer to those individuals from non-white British communities. So I'm the Deputy Lead for Research at Your Ross Hospice. As I mentioned earlier, this is the Leicester, Leicestershire and Rutland Hospice. And our vision or long-term aspiration for our society is that everyone with an incurable illness has a right to excellent care. And this should value and respect their uniqueness and their own choices. And people should be enabled to live and die with dignity and with appropriate and compassionate support for themselves and their loved ones. So a bit about our population. Leicester is one of 3 super diverse cities in England. That is, we have a minority majority with a total of 59.1% of people coming from minority ethnic backgrounds, 13% are Muslim and 12.3% are Hindu. And people from both religious groups are ethnically Indian. Now, the ambitions framework for palliative and end-of-life care in England describes what good care looks like. And I just want to draw your attention to statement 1. Each person is seen as an individual. And statement 5, all staff are prepared to care. We also know from evidence collated by ourselves and colleagues within the room that there are lower levels of advanced care planning with people from ethnically diverse backgrounds. Ethnically diverse communities are less likely to access palliative care and palliative care services such as hospices. And we know from work undertaken by myself and Christina and other colleagues here that evidence suggests that healthcare professionals often report both a lack of confidence, knowledge and skills in undertaking end-of-life care planning and in providing culturally sensitive end-of-life care for ethnically diverse patients. And that's because little is known about how end-of-life care planning and the model of, for example, resuscitation decision-making fits with somebody's social, cultural, religious values and beliefs. what we do know is that it's really important, pertinent to have an understanding of cultural as well as individual preferences and diversity. It's essential for developing effective end-of-life care planning, and also to enable patients and families to understand and appraise options open to them when it comes to end-of-life care. So with this in mind, after several attempts, as Christina I'm sure will support here, we managed to secure some National Institute of Health research funding under the Health and Social Care Delivery Research Funding Programme to undertake a 35-month qualitative study across Leicester, Leicestershire and Nottingham. And this study was the Thinking Ahead study and explored the barriers and enablers to end-of-life care planning with patients and their families from ethnically diverse backgrounds. Now, Lauros Hospice was the host for the project, but we also collaborated with a number of colleagues from University of Leicester, Open University and Nottingham University. But the key individuals that helped us shape this project were most definitely our public and patient informants. And I've mentioned Irfan Murajani, who's obviously listed here on the study report, and he was actually our PPI lead, and I know he's going to be talking more about this in a following presentation. But the project consisted of 3 separate work streams, and the first work stream consisted of 18 longitudinal patient case studies. Within these patient case studies, we spoke to patients who had been identified by healthcare professionals as being in their last year of life, so they were terminally ill patients, and the project started at the end of 2018. So we spoke to these patients. We also spoke to their family caregivers and healthcare professionals involved in their care up to 3 times over a period of 6 to 9 months. And this was with a view to finding out about their experiences of having end-of-life care planning conversations. What had gone well, what hadn't gone so well. Had they even recognised that they'd had an end-of-life care planning conversation? Had being part of this project encouraged them to have that end-of-life care planning conversation? Now, in terms of the background of these individuals, these patients are all aged from 40 to 96. The majority of the individuals had cancer, and in terms of their ethnicity, they were quite representative of the population that we served. There were some Indian individuals, Caribbean, African, but we also had individuals from Pakistan, Yugoslavia, and individuals who describe themselves as Chinese. We then undertook separate interviews with 19 bereaved family carers, and these were individuals whose relative that they're care for had died in the last 3 to 12 months. And they talked about their experience of end-of-life care planning, what had gone well, what hadn't gone so well retrospectively, what they might change or what could be changed. And again, the deceased patients were from a range of diverse backgrounds, including Indian, African, Caribbean, Pakistani as well. And the findings from these 2 work packages were then analysed using a thematic approach to analysis. They were analysed separately and then triangulated. And during this triangulation, 8 key themes emerged. And then working with a professional storyteller and writer, Andrew Barrett from Excavate, we developed these themes into 8 fictionalized stories. So these stories are very much based on the interviews and the case studies that we conducted. And this was with a view to presenting these stories in stakeholder workshops to develop an understanding of how we could utilize these stories. As people have mentioned earlier in the earlier presentation this morning, stories are powerful, and we want to know how we could utilize these stories to develop resources for healthcare professionals in supporting them to gain that knowledge, give them those tips in having those end-of-life care planning conversations with individuals who were from a background that wasn't necessarily their own. So the stakeholder workshops included individuals that were lay people, faith and community leaders, healthcare professionals, educators and academics. But I'm not going to talk any more about the methodology. As I say, the report has been published and you can have a look at that at your leisure. But for now, I want to talk to you about the findings. And those of you that have been present throughout the day have known that we've used the term Sawubona quite a lot. And obviously it's in the title of the presentation, the conference title today. So you know that Sawubona is a Zulu greeting. And Sawubona very much represents for us how healthcare professionals and patients want healthcare professionals to see and know them. They want to be seen and known in terms of what's important to them as a person, in terms of their culture, in terms of their background. And what I'm going to do now is play a video for you, which will talk more about this. And it will also discuss the key themes that emerge from our data. And within this video, you'll also meet some of our amazing public and patient informants. So hopefully the technology works and you'll be able to hear this. Sawubona is a Zulu greeting which means I see. Patients and their families want to feel seen, known and heard. And to do that, we must respect their personal, cultural and faith beliefs.
But what we found is that the health profession does not understand and are not able to understand that the real differences in how to approach our care and our needs. That is a key thing. How does one begin? Where does one begin with that?
It's really important carers and caregivers and professionals understand exactly what it means from a spiritual and cultural aspect, understand what a Muslim person is, or what a Jehovah's Witness might need, or a Rastafarian, or somebody from the African community, or the West Indian community, or from the Chinese community, from the Irish traveller community, wherever it might be.
To be culturally sensitive, to be sensitive to her background, her religion. I guess just checking with the family to see if it's okay, if they do want to do something. Is it okay? To be aware of her dietary needs, her modesty, to be aware of her scripture needs.
So they really need to look at the notes, find the information, have a small group of people that know about me and know about your circumstances, know about what treatment we can give you and what the outcome could be.
To help healthcare professionals implement our findings, we've developed an e-learning resource, helping you practice.
This is from the Thinking Ahead Loris project. If you want to find out more, please contact us through the email below.
Okay, so what our findings indicate is that what constitutes good end of life is influenced by the intersectionality of a number of factors, which include but are not limited to just those of beliefs and culture. All people, regardless of their ethnic background, desire personalised, compassionate and holistic end-of-life care. We don't need to change the holistic framework to address the needs of patients from ethnic diverse backgrounds, but it's in the delivery of this framework and the additional range of skills that are required that is the challenge for healthcare professionals and services. So how do we help professionals to do this? We've talked about in that video the e-learning resource that has been developed. And what this resource really highlights is that when we meet people, we see and hear a number of things about them that give us information about them, which we quickly link to our prior knowledge and sometimes our assumptions. And this is something that Marie talked about earlier. So you may have already seen the iceberg model before, but what this highlights is that certain things about individuals when we meet them are very apparent, but they're just the tip of the iceberg. But other aspects, such as their way of living, their beliefs, their culture, can be hidden, but often very influential. Professionals need to have some insight into how culture might play out and the drivers to behaviours and not assume things. And if there are language barriers, then we need to find ways of bridging those. So I've already mentioned that we developed these 8 stories, and I said, stories are powerful, as Debbie Lewison Roberts mentioned in her presentation earlier. And these stories are embedded as part of our learning resources that have been developed, this e-learning resource. And what I want to do now is play one of these stories for you. And this is Shamak's story. And this story illustrates themes of models of caring, and within that, the duty of care and burden of care, but it also illustrates the theme of misunderstanding and mistrust. And I want you to have a listen to this story and think about what immediately comes to your mind when you hear Shamak's story. Let me just check the volume of this.
Remember to stay calm. Don't let my father down again. Don't get angry again. try not to be scared again. But he can always see when I am hiding things. What is it, Sharmak? What is it you are not telling me? I should be at his bedside looking after him. I should be doing my duty as a good son. But instead I make him worry. And what can I say to him? That I am being called up in the middle of the night to be told to come to work. That I worry that somebody will report me. That I'll be sent back. And he'll be left here all alone. I know I was wrong to react like that. But I was tired. And he looked so weak. And you never know when you get to the hospital how things have been. Maybe he hasn't been able to explain to anyone that he needs the toilet or that he can't eat the food they've given him. And then the doctors started asking those things to me. How could he use those words? These things are in God's hands. Why were they giving up on my father? Did they need the bed for someone else? Someone who comes from this country? I didn't dare go back for a week after what happened. I didn't even go to the mosque to pray for my father because I had to work. I've never felt so frightened, thinking that his bed would be empty when I arrived. But there he was, sitting up, waiting and worried. What kind of person can do that to their own father? And what happens now? Who can explain to me what is really happening and what am I meant to do?
So that was a powerful story, but what would you see when you first meet Shamrat? Perhaps it's an angry young man who's caused an issue on the ward. That's what you might see as a healthcare professional. But what's less visible is that he's afraid of being deported. His employment is precarious and demanding. He doesn't trust that professionals want to do the best for his father. He is scared. He feels guilty that he's not doing his duty to his father. Marie talked earlier about cultural humility, and what we found is very much emphasises the need for that, because to optimise our work with patients who are from a culture that's different from our own requires us to take an approach of cultural humility. And to do this, we must actively listen to patients, learn from patients' narratives without assumptions or stereotyping. It's about being aware of our own culture and examining our conscious and unconscious biases. It's about being able to demonstrate authentic curiosity, being able to ask that patient, that family member, what do I need to know about you as a person to give you the best care possible? It's also about embracing complexity and particularity, because if somebody has had a negative experience in a healthcare setting in the past, that's ultimately going to have an influence on how willing they are to want to have that end of life care planning conversation with a healthcare professional in the future. Now, as I've mentioned, we've developed resources for healthcare professionals. There is, of course, the e-learning resource, which is hosted on e-learning for healthcare. But alongside this, we've also developed a learning guide for healthcare professionals. And this also has transcripts of the 8 stories that I've mentioned. There are also audio recordings of these stories, both 2-minute and 5-minute versions. And these are all available free of charge and hosted on the Loros website. And do use those resources. And find them on that link there. But if you do use them, please do let us know, because it's really useful for us to gauge the impact of this work. Now, one of the key recommendations of the Thinking Head study was to enhance the skills and confidence of professionals in working with interpreters to support patients who have limited English. And the significance of interpreters was mentioned earlier today in Ollie Claiborne and Famid Ahmed's presentation, because interpreters do play a crucial role in facilitating effective communication. They're there to improve communication, bridging those language gaps. They can also support in culturally aligned care. They can help healthcare professionals navigate those cultural nuances, ensuring that care plans are tailored to meet the unique preferences and values of each individual. They can also promote autonomy. They can help promote patient autonomy, involving them, and of course, family autonomy as well, and ensuring that the end-of-life care process, a decision-making process, meet their wishes. Interpreters can also assist in conveying sensitive and complex information in a way that's fully understood by all and facilitate that inclusive discussions between professionals and their family. They can, of course, reduce misunderstandings as well, particularly around issues around conceptual translatability, such as what palliative care is, what is a hospice, what are the intentions in the use of morphine, so they can ensure that accurate information is conveyed and understood and reduce the likelihood of medical errors and cultural insensitivity. They can also help facilitate that signposting to services, sports services such as counselling, spiritual care and social services. So ensure that individuals receive comprehensive and holistic palliative care. Now, with the aid of funding received from Marie Curie, resources are being developed by colleagues that are present here today for use for staff who work with interpreters and patients and their families. And this includes a learning guide, which is in this image there, and also video and an e-learning module, which has already been developed. So e-learning focusing on communicating with non-English speaking patients. And again, that's hosted on e-learning for Healthcare Hub. So to summarise, there are a number of resources that are available which healthcare professionals can utilise. And I know Marie talked about cultural humility and the humble model. And again, I would urge you to utilise this in your own practice. It's a really useful tool, as well as, of course, the new resources that have been developed. But for now, the last few seconds, I shall leave you with this. Thank you for listening, and I shall stop sharing my screen now. I can't hear you, Christina.
I was on mute. Yeah. Thank you so much, Sylvia. That was, I know it so well, but I heard some new things in it. So for those that haven't heard it before, I'm sure that brought a wealth of knowledge and nicely integrated with some aspects that Marie was talking about before, which is super. And we've got questions around both of those to come later to learn even more. But for now, Sabrina, I believe you have joined us. I think I've seen you.
Yes, I am here. Hello.
Yeah, brilliant. Nice to welcome you. Are you all ready to go?
I think so. Let me just try to share my screen.
And I'll just give a little introduction to you, Sabrina, if that's okay. So Sabrina is a colleague who's a clinical senior lecturer at King's in London, and she's also a consultant in palliative medicine and is leading a lot of work around policy in equity in palliative care for people from diverse ethnic communities. And you're going to have a particular focus today on shifting the focus from equality to equity. Thank you, Sabrina.
Thank you. Just to check, can you see my slides, or can you see my slides plus notes pages?
I can see your slides plus notes.
Let me just switch it around. Okay. That should be the right way around now.
Yep, that's correct.
Yeah, brilliant. Yes, no, thank you for inviting me today. And it's great to follow the previous two presentations, and in particular Zobia's, because I think there is a lot that is in common, and I think hopefully I will build on the great work that Zobia and her team have already done. So we conducted some work during COVID called the CovPal project, and I led the work around the ethnically diverse patients. And what we aim to do is on this part of the project was to map and develop insights into the response of specialist palliative care services caring for patients and families from ethnically diverse groups during the first wave of the COVID pandemic. So we did this through a cross-sectional online survey of UK palliative care services during COVID, and we collected quantitative data and qualitative data in free text comments. So the main bulk of the data that I just want to present today is around the qualitative comments, and they were in answer to these questions, really. So we asked, have you encountered patients or families with COVID-19 who are from Black and minority ethnic groups, yes or no? An open-ended questions of are there any differences in how you are supporting or reaching them, and are there any groups, different religions or cultures where you have found supporting the individual needs of people affected by COVID-19 particularly challenging? So the results were fantastic. We had 277 services reply to the survey, and interestingly enough, only 93 of those services had cared for ethnically diverse patients. Really, for me, reflecting on the settings of those services was really interesting. So 49% of the services that are looked after ethnically diverse patients had been hospital teams, and less so home or inpatient or hospice teams. Services were much more likely to be hospital palliative care teams than inpatient hospice or home teams, despite other work showing that hospice and home palliative care teams were reporting they were much more busy during this time. So the qualitative work really showed 5 main themes that emerged. They showed that there was disproportionate adverse impact of restricted visiting on people from ethnically diverse groups. And as some of you might remember, there were blanket policies really brought into place around visiting restrictions, which were completely understandable. But what that meant is that for some people from ethnically diverse groups who often may have large groups of people coming to the bedside at the end of life, that wasn't able to happen, and that caused a lot of distress. There was compounded communication challenges. So some people from ethnically diverse backgrounds whose first language wasn't English lost their translators, who were often family members. And also at that time, we were losing face-to-face translators in hospitals. And it meant that people from ethnically diverse groups weren't able to communicate their basic needs to hospital staff. In addition, there was unmet religious and faith needs as well. For example, in the praying at the end of life, and also in the washing of the body. And this was having undue distress as well. It was really interesting to see some of the comments from the services, the palliative care services, and they quite clearly were reflecting that there were ethnically diverse groups who had previously mistrusted palliative care services, and with the added layer of COVID, that meant that mistrust grew, and people were closing the doors to services. So one of the things that we did do in our quantitative data, when we asked that question on did you care for them differently, it was really interesting because of those 93 services that had cared for ethnically diverse patients, around 60%, or almost 2/3 of those services stated that they hadn't treated ethnically diverse patients any differently. So, and the qualitative comments supported this. So there was a focus on equal rather than equitable care. So we reflect in the paper that we published that actually palliative care, within palliative care, we very much pride ourselves on delivering a personalised or individual response to patients, and I know that's something at the heart of what we do. And then we, but one of the things that we reflect on within the paper is that actually by treating people equally, we fall short of delivering high quality palliative care outcomes for those who are underserved. And this really comes from an inability to respond to cultural and religious needs, leading to disproportionate impact and distress on these groups, as reflected in our work, really. And so we would propose in the paper that to deliver an equitable response for all underserved groups, i.e. achieving high quality palliative care and outcomes for everybody, that actually, whilst personalised care is important and it's what our holistic assessments are based on, that actually there's an added layer as well of thinking about what happens on an organizational level in impacting outcomes. For example, what was demonstrated during COVID, where there was a restriction on visiting, which, whilst it was a blanket policy, it impacted the ethnically diverse groups more. So actually we need to consider what we do on an organization level to mitigate that and really have an awareness of that. And actually, I think that one of the things that we don't do enough of is when we bring in different models of care or different services or make a change to our services, that we don't actually do make those changes or those adaptations with those ethnically diverse groups at the centre of them, and actually thinking about who we're leaving behind. So I'm a big fan of redistributing resources, to think about who is already getting the best and most and who is getting the least and worst, and think about having equality of outcomes, not equality of resources. So I don't think that would be fair or equitable in palliative care until that has happened. And I think that one of the things that was demonstrated within our qualitative work was that there was deficit thinking, that if there was a failure to engage with these groups, that the fault very much lay with the patients or the families, that it's their fault that they're not accessing the care that we're giving, rather than reflecting on what the services were doing. So I think really thinking about how you deliver cultural congruent care, and thinking about the simple things, really, about thinking about your outward facing literature, your making sure it's in the right the different languages which are appropriate, and it meets the health literacy needs of the groups that you are trying to reach. And that's just one way to do it. So one of the major things that we talk about in this paper is that to date that palliative care has been developed and really built with the white British group as the building blocks, really, and really thinking about the dominant culture, but actually shifting the focus and thinking about centering at the margins, really developing models and services that meet the needs of those at the margins first, needs to happen. Okay, so when we completed this work, we did publish it in a manuscript, which is here and in BMJ's Supportive and Palliative Care. And I'm delighted to say at the time it was picked up by 4 news outlets and has been downloaded over 15,000 times. And since then, actually, this research has been cited as evidence of racial inequity at the end of life in UK government policy, but also it's been cited in World Health Organization policy as well, with regards to evidence about transforming the health and social equity landscape. So whilst we did develop this the paper, write the paper and get it published, and it has been picked up. I think a big concern for me at all times has really been impact on the ground. You can write a paper and people can may or may not read a paper, but does that translate into actually people changing their practice? And that really then motivated me to apply for another grant, which was actually a medical research foundation grant, which is for a film. We developed a film for health professionals, and it's actually called Palliative Care, Shifting the Focus from Equality to Equity. So what we did is took the findings from the paper and did focus groups to really with ethnically diverse patients and health professionals, and really talk to them about how we took those findings and translated it into an educational resource. And then I went up and down the country interviewing patients and health professionals, and this is me interviewing lovely Kate at Greenwich and Bexley Hospice, and really using the voices of patients, health professionals, and to deliver this educational film. And the educational film aims to improve palliative care health professionals' understanding of the unique needs of patients and families from ethnically diverse groups and why they matter, and really to give everybody the stepwise way to change your practice as an individual, but not only change your practice as an individual, but change your practice as an organisation as well. So this film is available on YouTube, and it has already been viewed 3,500 times to date. So I would encourage you to have a watch as well, if you can. In addition, we have also developed an e-ELCA teaching where you watch the film, and then there are 8 questions around equality and equity and delivering equitable care in your practice, so as a learning resource as well. So just to acknowledge that this funding, the film was funded by the Medical Research Foundation, and it wasn't just me, it was all of those great co-investigators there as well, and the big wider CovPal project as well. Thank you.
Sabrina, thank you so much for bringing another dimension to some of the interventions that are at play to improve. Irfan is a master communicator in all sorts of ways, and indeed as part of his professional work. So Irfan, you may want to introduce more about yourself, but I know that you're going to talk particularly about a subject close to your heart, the spiritual care of Muslim people, really in those last aspects of their life, but I'm sure it will go beyond that. Thank you, Irfan.
Thank you, Christina, for such an illustrious introduction. I'm quite scared that I won't be able to live up to your expectation now, but I'm very grateful and very delighted to be part of this wonderful day, this wonderful conference. And I'm just going to share my screen now so we can get underway. So let's go. Right. Please let me know when you can see my screen. And can you hear me all? Give me a thumbs up if you can. Okay, perfect. All right, everyone. So I'd like to begin by just saying, Sawubona. I see you. You're important to me, and I value you, and I genuinely mean that. And I'm delighted to be here. My name is Irfan Mururajani, and I sort of quite often sit when I'm reflecting and wonder, how did I actually get here? I'm on this stage with such illustrious academics and research experts and clinicians. So, and here I am, just a lowly layperson. But the good news is that we're towards the end of the day, which is great. The bad news is you've got to listen to me for the next 20 minutes or so. So I'll try and make this as engaging as I can, and hopefully sort of a different take on what we've heard so far, but in line with the themes that we've seen. So for the next 15 minutes or so, I'm going to talk about the importance of Shahada in end-of-life care and end-of-life care planning in specific. So a bit of a shameless plug from myself. I'm on LinkedIn, and that's my Instagram handle. So please feel free to reach out and connect with me, because I'm always interested in making new friends and talking about this work. As Christina mentioned, it's very, very close to my heart. So let me just, there we go. And in true style, it's not working. Can you see the next screen?
Sorry, no, it hasn't moved on yet, Irfan.
Has it not moved on?
Not as yet. No.
Let me try again. Okay, let's try this. You see that?
Yeah.
Okay, here we go. Right. So PPI and me. So as Zobia alluded to earlier, I'm some sort of PPI expert. That makes me sound like a dodgy insurance salesperson, but I'm not. So rest assured. However, how I got involved with patient public involvement was through the experience I had when my mum was coming to the end of her life with Loros Hospice in Leicester. And it was an experience which has really stuck with me, and it has changed my life. And I mean that sincerely. It changed my life to the extent where I felt compelled to give something back. And I always took the opportunity to try and give something back to the organization, purely because, from a cultural aspect, um, anyone who looks after your mother, it's a very honorable thing to do. It's a very noble thing to do. And we, as people, as Muslims, we believe that there is no one more important in your life than your mother. You only have one mother. Um, to the extent where, if you want to find paradise, look beneath the feet of your mother. So I always felt compelled and obligated to give back to Loros and what they did, and really got involved with the Thinking Ahead study. And that opened up so many doors and avenues for me personally. But it allowed us to come together and really try and be innovative in making sure that the end of life care experience is a universal, uniform aspect of care, and what we can do to improve that. But I must say that I'm not an expert, so I'm not one of these guys. I don't profess or claim to be the expert in the field. What I try to do is I try to make connections, and I try to open those conversations so we can all feed back and give something back into these services, which are so important, are so fundamental in our society, especially when it comes to giving care. And quite funnily enough, within my community and with my friends and my circle, I'm known as the Loros guy. So people quite often reach out to me when they want to learn more about hospices and hospice, because there is this perception, wrong perception, that hospices are care homes, and therefore, they're seen as this scrap heap for people, but they're not. And I learned that through my experience. And I must admit that prior to my mum going into hospice care, I had very little understanding of what they do. But so just to caveat that, I'm not an expert. But let's move on, shall we? So, trying to give back is, I want to see change. I really want to see change, because a year after my mum passed away in Loros, my paternal grandmother passed away in hospital, and the experiences of both those people dying were at the complete opposite ends of the spectrum. And I thought to myself, oh my gosh, we had this wonderful experience, which was, life affirming in many ways. And then dying in hospital on a Friday evening for a 92-year-old woman with dementia was just, it was awful. It was horrible. So, there must be something we can do to change that. And again, this is the fundamental, or the main motivator for me to be involved in this, is I want to see change. I want to see everyone experience the absolute best they can, not just as patients, but also you guys as caregivers and researchers and academics. So that's the main reason why I got involved. And looking at the Declaration of Faith sort of was an offshoot from the Thinking Ahead study. I was out for one of my daily walks when Christina rang me. And I always get a bit nervous when Christina rings me, because I'm thinking, oh my gosh, what's she going to say now? What is she going to rope me into? And she knows that whenever she talks to me, she's going to present something so irresistible that I can't say no. So for me, this came out of the Thinking Ahead study, and it got me thinking about, well, how do we administer sacred religious rites to people who are dying? Or how do we ensure that they get the chance to fulfill those wishes, but they may not be able to physically do that themselves? So we started having these conversations, and we organized a meeting around looking at the declaration of faith within Islam for Muslim patients who are towards the end of their life. And for those of you who are Muslim amongst the participants and the delegates today, you'll recognize this. So this is the declaration, the Shahada. Now, the Shahada is an Arabic word which means witness. And when you give this declaration of faith, you bear witness. And what this is Arabic, which says, La ilaha illallah, Muhammadur Rasulullah. And what this translates to is that there is no God but Allah, and that Muhammad is his final messenger after a long line of messages. And this is it's the fundamental aspect of Islam. It's the most important thing in any Muslim's life. This is the first pillar of Islam. And without this, or without this declaration or this commitment or this belief, everything else for a Muslim is quite meaningless. So this is what the Shahada is. It's a testimony. It's a declaration that you firmly believe in your heart with sincerity, with authenticity, that there is no God but Allah, and that Muhammad is his final in a long line of messengers. So what is the significance of the Shahada? Well, in terms of healthcare, or in terms of coming towards the end of your life, there are several aspects to what this means to Muslim patients. First of all, it's a great means of comfort and assurance. People have a firm belief around what this statement means. It is the central tenet of Islam. It's what everything is built upon. As I mentioned, it's the first pillar of Islam. So it is the most important thing. And for Muslims, it gives them comfort knowing that upon their deathbed, as they're about to take their last breath, if they can recite this or utter this in any way, it's a mean of seeking forgiveness for them. And that is very, very soothing to a Muslim, because it doesn't matter how you've lived your life. Muslims believe that if you can, with your last breath, say these words, you are in a good place spiritually. And it's also the firm belief that the soul continues its journey after death. So once the soul leaves the vehicle, which is the body, it continues on its journey towards the afterlife. And as Muslims, we believe that our time here on this earth is very temporary. It's a transitionary phrase. And it's also a fundamental reminder of who we are as Muslims and the duties that we have in terms of being good Muslims. It's not just about praying, but it's also about our etiquette, our behaviors, and how we interact and what we contribute to society as a whole. The Shahada itself is also very important in terms of acting as a guide for making decisions. It's very, very, very influential. It's something which dictates people's lives. We live and die by it, literally. And it helps us to understand who we are, and it brings us back to what is most important in terms of our belief system. The role of religious scholars and or imams at the end of life is very, very important, is very, very significant. 10 years ago, I wrote a piece for Leicester City Clinical Commissioning Group looking at the importance of death in all religions. And it's safe to say that regardless of your belief, whether you have a belief or you don't, dying or the moment of death is very important. It's very significant, and people want to make it as comfortable as and take away as much fear from it as they can. So having scholars there is very, very important. And going back to what I said about involving about improving care, I really believe that faith leaders have an important role to play. We heard, the likes of Jonathan talk about how we can unlock communities. I like to flip it, and we as organizations, we try and engage with communities, but I do believe, and I always say this to my community, that we have a role to actually accept that invitation and be forthcoming with information and willing to engage, because we have very we're a very reactive community. There's a lot of knee-jerk reactions. Oh, I didn't get the care that I wanted. I didn't, they didn't understand this. Yes, but what have you done to make sure that the organizations or the institutes that you access understand more about what you need? Where's your role been? So for me, I'm a great advocate for that. And again, I mentioned that the Declaration of Faith is the reinforcement of the core principles of Islam and the belief that the ultimate prize is getting entry into paradise and living comfortably in the hereafter. Moving on, the Shahada is very, very important when we look at the afterlife. So, as Muslims, we use our whole life from the moment we are born to the moment we die as preparation for what is to come and the real life, as we like to call it. It's very important that we use it as the basis for our conduct, our etiquette, how we pray, and we remind ourselves. So many of us will, throughout the course of a single day, will remember this, will recite this, whether whatever it is we're doing, and the role of loved ones at the time of death is very, very important. So, in the case of my mother, who was unconscious just before she passed away, myself, my brother, her sisters, we were reciting this in the hope that whilst, even though she was unconscious, she may have been able to hear it, and that may have been able to encourage her subconsciously to try and recite that in her mind, or at least be aware that she is about to transition into the next phase of the soul's journey. So the role of loved ones is very, very important. To recite it audibly and quietly, or whisper it into the ear of that person, is really, really important. So it's a very unifying statement. It unites people, it unites communities, and it's an unequivocal force that brings people together. As I mentioned before, it's a great comfort. Whatever happens in life, whatever curveballs we life throws at you, it's a great leveler. It brings you back down to earth. It gives you perspective. It gives you an understanding of what the real goal is. So for us, it stops us from being complacent, or it should do. And we're seeing at the moment, there's lots of turmoil in the world, and it allows us to be grateful for everything that we have, and that we shouldn't complain, because whatever we're going through, it's almost a guarantee that there are people somewhere, somehow, going through something that is much, much worse. And as I mentioned before, the main theme about this is that the Shahada is a connector. It underpins everything within Islam, and for a Muslim, regardless of how they've lived their life. So there might be someone who doesn't pray, or drinks alcohol, or has a series of vices. As they approach death, they try to reconnect with their faith, and if they are able to recite the Shahada in their dying moments, then we believe that God will forgive all of their sins and cleanse them as if they were a newborn baby as they journey into the afterlife. So it's a very powerful tool in a Muslim's armory in that respect, because we don't judge people on how they live their life. We don't say, oh, well, you've got no chance, mate. Sorry, but there's no point in you reciting it. Everyone, we just don't know. And only God can judge. So it allows that patient to reconnect up until the very final moments of their life. And that's something which should not be underestimated, especially when we're talking about advanced end of life care planning. So how do we implement this practically? Well, I think there's a number of ways, and having conversations, and we talked about this with Thinking Ahead. Having conversations about end of life care planning is difficult, but I don't think it should be undertaken with fear. If we can do it respectfully, and if we involve the right people, it can be a very positive experience. And again, this is where I go back to involving, or making community or faith leaders accountable for saying, right, okay, you need to tell us what we need to do, because a lot of people, especially in Islam and South Asian Muslims, they will look towards the imams and the scholars to actually give permission. So, for example, if there's a patient who has a DNR on them, the families will say, no, 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 we must resuscitate. You know, we believe this X, Y, and Z. But sometimes it's the imam or the faith leader will say, well, actually, it's fine. We have to let nature take its course, and your loved one will not be sinful for not trying to prolong life. So there are elements of cultural sensitivity, but I do believe that everyone has a responsibility in the end of life care planning process, and involving families, loved ones, people that the patient or the person might be close to is really important. You know, get a broad picture, get a wider sense of what's happening in this person's life. Who are the movers and the shakers? Who are the decision makers? Especially if there's an instance where sometimes the patient might be impaired in terms of their judgment or their decision making. So getting family involvement, and don't be scared to speak to people. There are lots of people who are gatekeepers to their community, and we found that out with the Thinking Ahead study. There are some really key people who, if you can align yourself to them, will allow you access into that community. And I think this is something which is not confined to just Islam, but all religions. Certain communities, for example, the Chinese community, I believe that they don't even say the word cancer and those sorts of things. So there are ways we can do this, but it has to be done in collaboration. And it's not fair to say to the healthcare institutes and organizations that this is your job, this is your duty to go and unlock, as Jonathan Kaufman said, the keys to enter that, the keys to the door to enter that community. So I hope this is useful and making sense. But to conclude, the Shahada is it's more than just words. It's not just a verbal declaration or a reinforcement of faith. It is something that encapsulates the entire belief system for Muslims, and it is absolutely critical for any Muslim. If you ask any Muslim, 99.9% will say that yes, when it comes to my death, I would like to be in the state where I can recite the Shahada, recite this declaration, in the hope that God will forgive me for my life here on earth. So it is very, very important. And as Muslims, it's something that we actually pray for. So we ask God to say, give us the ability with our last breath to be able to undertake this declaration, this testimony, this bearing witness that there is only one God, and that Muhammad, peace be upon him, is his messenger. So there are many other elements that I could have talked about, but I was scared that I would be sort of teaching this wonderful group how to suck eggs, and God forbid, I don't want to do that. But I wanted to give some opportunity for any questions. So, Christina, Zerbia, I hope that's what you were hoping for in terms of my session. And to the participants who are with us, please ask your questions. Nothing is off limits, or there are no holds barred. There is no such thing as a silly question. So over to you.
Introduce my colleague at Loros, who is our director for the Centre for Excellence. And Camilla, you have the unenviable task, if you like, or maybe the enviable, of pulling together the summary of what you think the day has been about, and closing the day for us, and not forgetting the evaluation that we appreciate. Thank you.
Thanks, Christina. Can you hear me?
Yes.
Good. I am just going to share literally the last few slides of the day. Bear with me. Hopefully that will start to work. Pop that into. Is that now sharing with you guys? Can you see that? Have you got the right view? Excellent, Zabia. Thank you very much. I am only going to take a few more moments of your time to end this day. Thank you.
Just to say, it's not in.
We're not in the right. Let me just
slideshow.
Hold on a second. Better.
Yes.
Lovely. There we go. Thank you so much, Christina, and for handing over to me. And I am literally going to take a couple more moments of your time to bring this day to an end. But what an absolute honour to be asked to close such a thought-provoking conference. As Christina said previously, my name is Camilla Barrow. I am the new director at the Laura Centre for Excellence. Just before we let you go, I did just want to spend a couple of moments just talking to you a little bit about the Laura Centre for Excellence, and give you a little bit of information of what our building is doing and what it is serving. So it is a purpose-built building set in the heart of the East Midlands, and it is, as I said, purpose-built, solely dedicated to research, education and training in palliative and end-of-life care, really driven to improve palliative and end-of-life care, and for those adults nearing the end of life, and really strategically dedicated to tackling health inequalities and inequity in palliative end-of-life care, committed to that workforce development, and ensuring that equality, diversity and inclusion is central to all four elements of the Centre for Excellence strategy, so spread into our research, education, influence and practice, and ensuring that we are seeing that translation. So I just wanted to really talk to you about the Centre for Excellence, and we're incredibly keen to hear from others that really share that passion and share that drive to influence the improvements in palliative and end-of-life care that I think we all share is needed. So that just brings me really on to making a few closing statements, and first of all wanted to start with some thank yous, and really beginning with you, the delegates. A huge thank you as we've listened throughout the day and shared your thoughts and the debate that you have created, and sharing your own vulnerabilities in doing so. So thank you. It has been an extremely thought-provoking day and so much to digest. It almost becomes difficult really to summarise, but I do want to thank our guest speakers and of course our chairs for the rich conversation that I think we've all had today, and for everything that's been achieved and shared throughout the day. And of course, a huge thank you to Professor Sawubona Islam for your energy and for absolutely championing bringing us all together for tackling health inequalities and inequity in palliative and end-of-life care, and of course to our guest speakers and chairs. And really just a final thank you to our partners as well, so our Hospice UK and the Good Grief Festival, in particular Amber Morgan for joining us today, and of course Anita Hayes for her work that she's done to help champion this event, and to our colleagues at the Centre for Excellence, and without their help we would have struggled to bring this all together, and hopefully all had a good day together. Finally, I think we all have a responsibility, I think in the words of Jonathan, an obligation to go forward together to continue to tackle those health inequalities in palliative and end-of-life care. So some of the real tangible or achievable actions for us to do is join the forum. Absolutely continue to pursue research so we can learn more and have a better understanding, and to continue to build on our knowledge and understanding, and really look and share some of the resources that our guest speakers have shared with you today, and use them to move forward, to take us, hopefully, that we're not having the same conversations in 12 months time, in 2 years time, that we're starting to see some of this influence and change our practice for the better of our patients and carers. And as Christina said earlier, we have got our final piece of feedback that we would really like to gather from you all, your thoughts and your feedback in regards to today, how you found it is really important to us. There's a QR code now hopefully showing on your screen if you can see it. Use your smart device, as I'm sure most of you know how to do. and fill that form out. I'm advised it's only going to take you a couple of minutes at most, but that feedback will certainly help shape us and will offer us some reflection as well on how we move forward. I think that is probably enough from me now. Thank you all. When you've completed your feedback, you are completely free to leave this call.